The case scenario given to me was a 1.5-year-old female with complaints of delayed milestones, failure to thrive, bluish discoloration of nails, lips, tongue, fainting, and hospitalization. This history is suggestive of a cyanotic heart disease with a decreased pulmonary blood flow, most probably a tetralogy of Fallot. In history, I would like to ask about the functional status of the patient regarding the weight gain, any symptoms like sweating, tachypnea, poor feeding, recurrent respiratory tract infection secondary to right heart failure, and regarding the cyanosis, whether it is progressing and frequency of cyanotic spells, and the history of recurrent upper respiratory tract infection, other associated congenital anomalies, previous history of surgeries, and the medication history and family history of anesthetic difficulties. In examination, I would like to examine for the presence of parallel, cyanosis, clubbing. I will examine the height and weight. And then system-based examination. Apart from routine in serious examination, I will auscultate it for the presence of any loud murmur, like systolic murmur, uh, said, systolic murmur. Mm. And in investigations, I will ask for, since the surgery is not given,
You
not
can
mentioned
presume
in.
your surgery, whether it is corrective surgery or incidental surgery, whichever way you want to discuss, you can go ahead.
Okay, sir. Investigation, I will ask for routine investigations like CBC, hemoglobin, hemoglobin and hematocrit to see the degree of polycythemia. I will ask for RFT, LFT coagulation profile, mm, uh, and blood grouping and typing, and platelet also, platelet and total count. Usually, the platelet will be decreased and the total count can be increased, which is suggestive of infection. And specific investigation like chest X-ray, which will describe show a classic boot-shaped heart and oligemic lung fields and concave pulmonary vein. ECG, there will be a right ventricular hypertrophy and right axis deviation, and I will see the rhythm, whether there is any atrial fibrillation. Mm, In echo is compulsory. I will ask echo to rule out the degree, to see the degree of right ventricular outflow tract obstruction, direction, degree of shunt, uh, intracardiac anatomy, right and left ventricular function, and coronary anatomy. I will also ask for ABG, and I will monitor the SpO2 um, and preparation. Uh, since this is an unprepared cyanotic congenital heart disease, I will give infective endocarditis prophylaxis 30 to 60 minutes prior to procedure, like amoxicillin or ampicillin. If they're allergic to amoxicillin, ampicillin, I go with azithromycin or doxycycline. And I will avoid prolonged fasting periods since and I will give fluids to avoid dehydration, and I will pre-medicate the patient orally with midazolam 0.5 mg per kg 30 minutes prior to induction or with ketamine. And OT preparation, I will set the OT temperature to 25 to 26 degrees Celsius, and I will make sure that the IV tubes are free from air bubbles to prevent paradoxical air embolism. And I will arrange all the resistive drugs necessary to manage the hydroxyl spell. Mm. Monitors, I will, apart from routine monitors, I will place an invasive arterial line and a femoral central venous CVP line also. And goals, in this case, is to maintain the SVR and decrease the pulmonary vascular resistance. So the preload is increased or judicious preload, afterload is increased or maintained, contractility is maintained, and rate is kept normal. We should avoid tachycardia, rhythm is maintained, sinus rhythm, and avoid ischemia. Decrease in order to decrease the right to left shunt and maintain ventricular function and oxygen delivery. Mm, Plan will be, if it is a corrective procedure, um, general anesthesia, uh, corrective surgery is done and done via median sternotomy on a cardiopulmonary bypass. Mm, Drug of choice, I will induce the patient with fentanyl, ketamine, since it increases the SPR, along with esmolol, which controls the heart rate and decreases the inferior spasm. And the relaxant of choice will be atracurium or vicuronium. And maintenance with air oxygen monitors and sevoflurane. I will also continued dexamate infusion, warm IV fluids, and I will make sure that the IV line is free of air bubbles, adequate hydration. I will avoid hypoxia, hypercarbia, acidosis, and hypothermia, and sympathetic stimulation. So I will maintain a deep plane of anesthesia, and I will take an ABG prior to after induction and prior to extubation, and pain management multimodal with intraoperatively with fentanyl, and post-operatively usually they are extubated on the day after the surgery. Analgesia, multimodal analgesia. Patient are taken care of the high dependency neonatal.
Okay. You have completed? Okay. With the limited findings given in your case scenario, you started off saying that this patient has got bluish discoloration, which is indicative of cyanosis, and you made a diagnosis of cyanotic heart disease, tetralogy of Fallot. Yeah? Did you ask anything about the birth history? How the baby was born? Was it a full-term delivery or was it a premature delivery? And when was the cyanosis noticed? Was it not? Now it is the baby is 1.5 years old. If supposing it is a cyanotic heart disease, as you made out your diagnosis of tetralogy of Fallot, what would have been the condition of the baby at the time of birth?
So, because of the patent ductus, there will not be cyanosis at birth.
Okay.
And
But
later,
anyway, it should happen, it should
yes,
manifest at some time or other. Can
yes, sir.
cyanosis be present at birth itself in some cases?
Yes,
Should
sir.
it be there
And
because of patent ductus? It's always necessary that it is not exhibit at the time of birth and occur only later? Or in some
yes, sir.
cases it can occur even at birth?
It can
In those
occur at
days, they
birth.
used to
There is
say there are blue
supravalvular.
babies, blue babies are born, isn't it? Even at the
Yes,
time
sir.
of birth, they are very cyanosed. If supposing a baby is born severely blue at the birth itself, what does it indicate?
There is severe pulmonary atresia.
Hmm.
There is a Eisenmenger syndrome or a transposition of great arteries.
There is an anomalous variant
And
of
yes, sir.
pathology of
Total.
Fallot where there is absolutely no blood flow into the pulmonary circulation. So the entire deoxygenated blood is getting shunted from the right side to the left side, and that blood only is coming into the systemic circulation. And majority of the time, do these babies survive up to 1.5 years?
If they are pink tests, they can survey, sir.
No. If they are severely blue at birth, is there a chance of that baby to survive up to 1.5 years?
This is uncorrected of blue.
It is a very severe form of tetralogy of Fallot. Unless an immediate surgery in the neonatal period itself done, like a Blalocta section or a palliative procedure is immediately done within the first few days of birth, usually these babies do not survive for more than 3 to 6 months. Okay? So you
Yes,
must
sir.
first of all ask about the history at the time of birth, whether the cyanosis or bluish coloration was noticed at the time of birth itself, or was it
Yes, sir.
noticed a few days later. That is point number one, which you have missed. Number two, if your diagnosis is tetralogy of Fallot, is it an isolated condition or can it be associated with other congenital anomalies?
It can be associated with other congenital anomalies. It can be
Congenital
a part of
anomalies.
Bacterial syndrome or Dijard syndrome, Chart syndrome.
Left lip and palate can be there.
Can be there, yes, sir.
Do you have to ask all this history? Whether
Yes,
my parents noticed any other associated anomaly or was it pointed out by the neonatologist or the pediatrician attending the baby at the time of birth, any records of associated anomalies made out and documented. That is the
Yes,
second
sir.
point that you should have asked. And third
Yes, sir.
point, in your scenario itself, it is given the patient has been in and out of hospital several times. Did you ask anything about the details? Why the baby was admitted to the hospital? What happened? How they overcome that? Isn't it? Even though the
Yes, sir.
case scenario looks very simple, there are a lot of things that you have to more information you require to get from the parents by way of history taking. Okay.
Yes, sir.
So
Yes,
what is
sir.
the reason for the recurrent admission to the hospital during this 1.5 years of growth of this baby?
Can be
What are all the
because of
possibilities? Hmm?
recurrent respiratory tract infections.
Recurrent
The,
respiratory tract infection. More than that, more
there can be
dangerous looking.
cyanotic spell,
Hyperspinotic spells
blood text.
or
Yes,
spelling.
sir.
Okay.
Yes, sir.
What
Yes,
is
sir.
the cause of hyperspinotic spells?
Sir, it is because of sudden decrease in systemic vascular resistance or infundibulous spasm,
Hmm.
uh, which will aggravate the right to left shunt, which will cause sudden desaturation and worsen and clinical deterioration. Mm, So the patient will have cyanosis, hypoxemia, or when the child cries or when the child is irritable or when there is pain or anxiety, cyanotic spell can occur. So immediately the child will squat and try to increase systemic vascular resistance.
Hmm.
Mm, and
Supposing the child is
our
only 3 months old, how will the cyanotic spell will be precipitated or caused? Now this is 1.5 year old child what we are discussing.
yes, sir.
Is there a possibility that even a neonate to exhibit a cyanotic spell?
Can
What are the conditions where it can happen?
so dehydration. Um,
Dehydration, hmm.
After feeds,
After feeds, crying, straining for
fever.
stool, fever. Very good. All these things
Defecation, sir.
can, yeah, straining for stool. That is what I said. Defecation, straining for stool, all crying, pain, okay, all these things.
Yes, sir.
And whenever there is a hypercyanotic spell history from the birth or even from the neonatal period, you have to know that it is mainly caused by the right ventricular outflow tract obstruction, RVOTO. Okay? And that RVOTO occurs only because of mainly infundibular spasm. What do you understand by that word infundibular spasm?
So, part of the right ventricle, upper part of the right ventricle,
Upper part of the right ventricle. Okay, what happens in upper part of right ventricle?
that will undergo spasm, so it will contract. So there is no
There is.
pulmonary blood flow.
Okay, very good.
No pulmonary.
So the pulmonary artery which carries the deoxygenated blood from the right ventricle into the pulmonary circulation for getting oxygenated through the alveolar capillary membrane, there is a bulk of muscle at the origin of the pulmonary artery below the level of the pulmonary valve. Okay, so that muscle can go into spastic contraction, preventing the valve may be normal, the origin of the artery may be normal, but just prior to or proximal to the origin of the artery, there is a group of muscle which is called the infundibular muscle, which will be hypertrophied and which will go into a state of contraction in these kids who have this pulmonary infundibular spasm, and that will prevent the blood flowing into the pulmonary major pulmonary artery, the common pulmonary artery. And because there is a large VSD, all the deoxygenated blood that has to go into the pulmonary vasculature gets diverted into the left ventricle. So
Left
there is
ventricle.
a increased amount of sudden increase in the quantum of deoxygenated blood coming from the right ventricle into the left ventricle compared to the normal quantum that is always going there even in before the spasm occurs. Okay, that is the reason why the cyanosis becomes much more deeper and severe with the saturation falling down much more steeply. So if you think normally the saturation, what will be the normal saturation in a patient with tetralogy of Fallot?
Around 80 to 85%.
Yeah, 80 to 85. During hypercyanotic spells, what will the saturation be?
Less than 50.
It will go down to almost 50% lower. It will go down to 40 to 50. Okay? And when it goes down to 40 to 50, what will be the problem?
Decreased oxygen release.
Which organ is going to suffer the most?
Brain. Brain is
Brain.
going to suffer the most.
So what will the brain do? If it is receiving less oxygen than what it has been receiving already, it is in a lower state of oxygenation.
It will stimulate the respiratory center and it will stimulate the respiratory center.
Respiratory center. So what will the child do?
Hyperapnea.
Hyperapnea. Patient will go into hyperapnea. They will try to take more air so that increased FiO2 can be achieved, but they cannot do that. They can only increase the depth and rate of respiration, and they will try to compensate to some extent. If they are not a walking child, if they are in the infant stage before walking, they will start breathing hurriedly and deeply to increase the oxygenation. But once they start walking, then they try to squat. Why do they try to squat?
By squatting, the femoral vessels get compressed. So there is
Only the
increase in the
femoral
systemic
or
vascular.
only the femoral? If you squat, you will not bend your knees.
Yes, sir.
So the popliteal will not get compressed.
Yes,
So
yes,
all the lower limb vessels are compressed, isn't it? Both the lower limb
yes,
vessels are
yes,
compressed, and that will help in that it will achieve by compressing the lower limb vessels.
that will increase the venous return. So it will decrease the right to left shunt, and also the oxidated blood from the viscera also reaches the ventricles. So to try to compensate for hypoxia.
Increasing the venous return is going to bring more deoxygenated blood only to the heart.
That will again stimulate the respiratory center, and there will be hyperapnea.
Already respiratory center is stimulated, but what is the most important advantage by squatting? You are making the vessels compressed, so heart has to pump against what? SVR will be increased. Systemic vascular resistance will be increased. Okay, that will prevent the rise to left shunt. That is the main thing that is happening. More than the venous return, if venous return comes, that is also going to be only deoxygenated blood. Okay, it may improve the preload. That's all, but it will not. It will rather aggravate. So the main advantage of squatting is to increase the SVR so that the quantum of pumping from the right side because of the increase in the pulmonary pressures is balanced or reduced so that the child will get back to the normal milder hypoxemic state or the usual hypoxemic state. Okay. So these are the two things. Did you ask about any possibility of any infection in the central nervous system occurring in this child earlier? Because of the hospitalization, one of the complications need not be always a hypercyanotic spell. For what other conditions other than recurrent respiratory infection and hypercyanotic spell, a child could have been hospitalized? Any
Because of
central nervous
seizures,
system complication?
seizures or loss of consciousness. Because of can be because of brain abscess or seizures.
Why does a brain abscess occur in a child with a tetralogy of Fallot?
Because of a large non-restrictive VSD, The blood from the right ventricle does not reach the pulmonary capillaries and escapes the filtering and the phagocytic action of the pulmonary vessels.
Very good.
So more prone to, so that blood will reach the brain and more prone for brain abscess. And because
Okay.
of the sluggish flow, because of polycythemia, secondary polycythemia, um, they are more prone for brain abscess.
Very good. And also because the brain is constantly in a low oxygenated state, there is a acidosis present in the brain tissue also, like any other tissue. So the three factors why they develop a brain abscess is one, the normal filtering action or the phagocytic action in the lung is not there because the blood is not flowing through the pulmonary circulation properly. And if there is any septic focus or any sepsis available in the body, that can be mixed in the bloodstream and that can directly get pumped into the systemic circulation and go to the cerebral circulation. And in the cerebral circulation, because the brain tissue is already suffering from hypoxemia, there is a mild acidosis which promotes or which facilitates this infection to happen. And if that is the case, the child can develop a brain abscess. So what will be the features of a brain abscess in a child with a pathology of Fallot? How will they present?
There can be fever, seizures, headache, nausea, vomiting.
So how do you identify or which investigation helps to find out whether there is a presence of a
MRI,
brain abscess?
MRI of brain
MRI
can
of the brain.
diagnose
Okay.
brain.
Should it always be necessary to do a surgical intervention to correct this brain
First,
abscess?
we can medically manage with IV antibiotics.
Excellent.
If not, we can evacuate the
We can
brain.
do a surgical drainage of the abscess. Right. Okay. So all these questions of hospitalization. So the three reasons why a child could have been recurrently hospitalized or repeatedly hospitalized. One is recurrent respiratory infection, worsening the hypoxemia. Second is a severe cyanotic spell requiring immediate treatment. Third is the associated complications like brain abscess or the infection elsewhere in the body. Okay. So how do you treat, supposing you said you will start esmolol intraoperatively to correct this hypercyanotic spells. Supposing it is happening in the preoperative period in this 1.5-year-old child, can you enumerate the steps of treatment of cyanotic spell?
So, preoperative, 100% oxygen. First, I will calm down the child by giving the child to the mother, or I will encourage knee chest position. I will administer morphine 0.1 mg per kg
Supposing
to
the child
decrease.
has not adopted the starting position, will you alter the position of the child?
We can bend the child's
You
knees
bring the child to what is called the knee
towards the
chest
abdomen
position. Okay.
position.
Even when the child lying down, you can bend the legs and bring what is called the knee chest position. Okay. Right. Then
If there is any dehydration, I will give fluid bolus, 15 to 20 ml per kg. I will give morphine 0.1 mg per kg. I will increase the SPR with phenylephrine.
what is the
5 to 10
reason for giving morphine?
Because it will decrease the respiratory stimulation. And
The
also
respiratory
it will
stimulation is a compensatory phenomenon. You want to decrease that? Nature itself has stimulated the respiratory center to produce a hypopnea so that
also
more oxygen can be taken in. Why do you want to
if
suppress that?
there is any pain or anything,
Will it cause pain, hypercyanotic spell? If it is precipitated by pain, you can give morphine. But even otherwise, morphine is one of the recommended treatment.
Relieves the spasm, sir.
Reduces the
Infundibular spasm, sir.
It
decreases
dilates the pulmonary vasculature.
the
Morphine has got a
spasm.
dilatory effect on the pulmonary vasculature so that the pulmonary pressures come down. This is the reason why we give morphine even in patients with pulmonary edema because of congestive failure. Okay, so it reduces the pulmonary vascular spasm or dilates the pulmonary vasculature so that automatically pulmonary pressures will come down and the quantum of blood getting shunted from the right to the left will be decreased. That is the answer for why you give morphine, not to suppress the respiration. And of course, it allays the anxiety which causes a sympathetic stimulation. Okay, so the heart rate will be also coming down. Why increasing heart rate is dangerous or not recommended in these kids?
Increasing heart rate will decrease the diastolic filling, and
Mm.
again it will aggravate the right ventricular outflow tract obstruction. So
Okay.
we need to give
The shunt
beta
fraction will
blockers.
increase.
Is
Right.
beta
Then,
blockers to relieve the infantile blood spasm and to decrease the heart rate.
mm.
And I will volume resuscitation. I will correct the acidosis with sodium bicarbonate. If intraoperatively, we can give manual compression of aorta. Mm.
What other important drug to increase the SVR you are missing in your answer?
The phenylephrine,
This is
direct
another
alpha
important.
phenylephrine.
You should never forget that. Phenylephrine is a mainstay in the treatment to increase the SVR so that you can decrease the quantum of shunt that is occurring because of the raised PVR, pulmonary vascular resistance. Okay, so the 5 steps you have to remember is give 100% oxygen, give IV fluid bolus, give morphine 0.1 milligram per kg IV, give bicarb for acidosis, give phenylephrine 5 microgram per kg or boluses of 25 to 50 microgram IV. Okay, these are the 5 steps that you have to remember. And of course, knee, chest or the spatting position adopted to increase the resistance and improve the condition. This is a very common question that they will ask you, which you have to remember, even if you have not experienced or seen a patient of tetralogy of Fallot. These are all the theoretical answers which you have to remember, right? Okay. And you have described all the details about how the and what are the clinical findings? I think you have not elaborated on the clinical findings, what you will find if you examine the cardiovascular system in this child. Did you mention anything?
Sir, beta blockers.
Yeah, beta blocker, propranolol, yes, correct. But that is also, beta blocker is available as a IV preparation also. So propranolol is will be a drug which is given on a long-term basis also in children who have episodes of hypercyanotic spells. It is given on a daily basis as a routine treatment to prevent these spasm. Okay, so that is also, again, sorry, I missed that, and it is an important part of the regimen of treatment for acute cyanotic spells as well as on a regular basis till the child gets the corrective surgery done. Right. Now, what are all the clinical examination findings you will get if you examine a patient with tetralogy of Fallot?
So there can be parasternal heave or thrill.
No, first start from the general appearance of the patient.
Is it
Will the
child
child
will
be
appear
for
silent?
1.5 years? Will it have adequate growth and weight?
No, sir, stunted growth and weight.
There may be stunted growth or inadequate growth. Okay, then
Child
what
will
are
appear
the
blue.
very obvious evident findings in inspection of these children?
Blue is discoloration of the lips, tongue,
Lips,
and
tongue.
cyanosis.
You call that as
Cyanosis and
cyanosis.
cysts.
What is the definition of cyanosis?
Deoxygenated hemoglobin levels more than 5
Definition,
grams.
not, I'm not asking the pathophysiology, I'm asking what is the definition, how do you define cyanosis? What you already told, that is the definition. Bluish discoloration
Blue
of
is
the tongue,
discoloration.
skin, nail bed, lips, mucous membrane is called Just like when you ask the definition of jaundice, is the yellow discoloration of the skin, mucous membrane, conjunctiva. The same thing holds good for cyanosis also. It is the bluish discoloration.
Discoloration.
What is the word cyanosis? Where is it derived from? What is the origin of the word cyanosis?
Cyan means blue.
Cyan means blue-green.
Blue.
Green-blue or blue-green color is cyan, C-Y-A-N. Okay, from that word only the word cyanosis has been described. So, what is the quantum of deoxygenated blood should be present in the body to exhibit this bluish discoloration in the various sites?
More than 5 grams per
Very
deciliter.
good. It should be more than 5 grams per deciliter of deoxygenated blood constantly circulating in the body to produce this bluish discoloration. How do you classify cyanosis?
It can be a central cyanosis, peripheral cyanosis, or differential cyanosis. Central cyanosis is evident by discoloration of the lips, and earbuds. Because of this is primarily because of decrease in oxygen content in the blood, and it releases on administration of oxygen. Whereas peripheral cyanosis is because there is
It is
cyanosis of
relieved by oxygen or it is not relieved by oxygen? Central cyanosis.
It is central cyanosis relieved with oxygen.
Relieved. Central.
Yes, sir. Yes, sir. Peripheral
Please think
cyanosis.
over. Central means it is mixing in the heart. Will it be relieved by oxygen? In tetralogy of Fallot, is it central cyanosis or peripheral cyanosis?
Central cyanosis.
Will it be relieved by oxygen? By giving 100% oxygen, can you make it to normal?
No, sir. Because there is constant shunting, we can't.
So central cyanosis is not relieved by giving 100% oxygen. Please remember that very, very firmly. You should not make a mistake. It is only the peripheral cyanosis commonly seen in the extremities, in the upper limb and lower limb, fingers and toes. That is the one which will be relieved by giving 100% oxygen, because it's mainly due to vasoconstriction. Okay, it is not the cause for too much of reduced deoxygenated blood present in the circulation. Okay, peripheral cyanosis will improve with 100% oxygen and FiO2. And what is the other thing that will cause improvement in the peripheral cyanosis?
Vasodilators.
Temperature. If you make the patient
Warmth.
Okay, warmth also will improve. That is why in the OT, when the patient is exposed without proper warming for in a low temperature for a very long time, your pulse oximeter struggles to pick up the circulation and give you the answer, the values, isn't it?
Yes, sir.
So that is a very important point that you have to remember. And you mentioned about differential cyanosis. What is differential cyanosis?
Cyanosis only in the toes, but not in the fingers. It can occur in
the conditions which can cause that.
Patent ductus arteriosus with recent emphysema.
It's pulmonary hypertension. Okay, then coarctation of aorta. Some cases of coarctation of aorta where the upper limbs are perfused well, but lower limbs are not perfused well. And some cases of hemiplegia. And even your AV fistula created for your dialysis, hemodialysis, that can also cause, I'm sorry, not AV fistula, but the hemiplegic patients on the affected side, they can develop unilateral cyanosis. Okay, so that is also called the differential cyanosis. What is the other important striking feature in these patients in the general examination? That especially in the digits.
Clubbing.
Clubbing, that has to be mentioned. Okay, what is clubbing? Again, what is the definition of clubbing?
Clubbing is the arbitration of the Shamrod's angle.
Shamrock's angle. Is there a better word than that? Or a simpler terminology?
Nail bed. Nail bed.
Shamrock did not describe the angle. It was Lowy Bond who described the angle. Shamrock may
Shamrock
describe some
sign.
other sign. Shamrock sign is different from angle. Okay. So it is the obliteration of the angle between the nail and the nail bed. In simple terminology, this is the description. It is the obliteration of the normal angle between the nail and the nail bed is what is called clubbing, and it gives a bulbous appearance to the tips of the digits, the toes and the fingers. Now, what is the reason for these children developing clubbing? In other words,
Getting into
what are the
policy.
theories of clubbing formation?
Because of polycythemia getting developed.
Polycythemia. Polycythemia is a compensatory phenomenon to deliver more oxygen to the tissues. Is that the cause for this clubbing? Because if at all you are going to get a case of tetralogy of Fallot in the examination, they will ask all the details about clubbing. Cyanosis and clubbing, you should be thorough to answer in the examination. So what is the basic thing happening in, because of the mixing of the deoxygenated blood with the oxygenated blood and the circulation of more than 5 grams of deoxygenated blood? Ultimately, what happens, what final effect is hypoxemia to the tissues, isn't it? So to compensate for that only, the RBC production is increased and you get polycythemia. What are the other compensations that the nature will try to do because of the lack of oxygen? Will it slow down the circulation so that blood will stay more for more time in the capillaries rather than quickly coming back to the heart?
Is there increase in viscosity of the blood?
Increase in viscosity because of polycythemia, but there is a slowing of the circulation at the microcirculatory level or capillary level. And when the blood is staying for a longer time, will the oxygen extraction be more or less? If the blood is circulating slowly in the microcirculation instead of quickly coming out, will the tissues be able to extract more oxygen or less oxygen?
More oxygen.
You are going to catch a train. If the train is delayed and it is waiting there, will you be able to easily enter the train or will you have to rush, run and catch the train?
I will easily
You can aramse go and get into the train, isn't it? The same thing. Tissues will be able to extract more oxygen. Along with that, more nutrients also will come. This nutrient, what will it do? It will cause more growth of the tissues, isn't it? So there is a increased proliferation of the fiber optic tissue under the nail bed, and that is what is lifting the nail and causing the obliteration of the angle. There is also some edema. Okay. So in the long run, there are 3 changes that are happening. One is obliteration of the angle. The second is fluctuation because of the fluid getting sent out from the capillaries. And third is increasing the size or depth of the tissues and the phalanx. Okay. These are the basic 3 things which are changes which are happening. And they will ask you what are all the explanations or theories for these changes to happen. What theories? When they say there are several theories, that means there has been not a definitive proven answer for this question. So everyone is suggesting their own theory. So what are the 3 important theories that have been proposed for this occurrence of clubbing? One is called neurocirculatory theory, neuroreflex theory. Okay, especially vagus nerve is stimulated, which causes this dilatation of the capillaries and stasis and increased stay of the blood in the capillary circulation. Number one. Second is there is supposed to be toxin theory, which releases lot of vasodilatory substance. But the third most accepted theory in the present day is what is called platelet theory.
Aviation.
Because of the increased platelet growth factor and vascular endothelial growth factor. These are the two growth factors which are getting stimulated, which cause increase in the number of cells, which increases the size of the tip of the digit. And why these tips alone are affected? Because that is the area where the lowest possible oxygen concentration blood is flowing. Okay, so that is where the more blood is staying and available there, which causes this increase in the gradual progression of the size. Will a child with a tetralogy of Fallot have clubbing at birth, or will it take some time for it to develop?
So it will take some time for it.
What time? How much time? It will take 3 to 6 months. Okay, in severe tetralogy of Fallot, they may have cyanosis at birth or within a week or 10 days when the ductus closes, and clubbing will happen gradually over a period of 3 to 6 months and start progressing and start increasing or worsening if the correction is not done. And that is the reason why they always advocate that a diagnosed child with a tetralogy of Fallot should undergo corrective surgery at the earliest within the first year of life, so that you can achieve the best possible result. Okay. Now you have done the possible correction. You have gone in for a total correction. What are all the post-op complications which you can expect, which can annul the effects of your corrective surgery? Two important complications.
This can be increased pulmonary blood flow, causing failures.
Yeah, we want the pulmonary blood flow to improve so that oxygenation can happen and improve the condition. That is the idea of surgery. But even after correction surgery, what two important complications can cause a failure of the surgery or cause an important complication which will not be tolerated by the child or the patient? What is restrictive physiology of the right heart post-op? Have you read about that? And what is JET?
There are junctional ectopic tachycardia.
Tachycardia. Okay, these are the two important complications which are very, very difficult for survival. Okay, why do these two things occur? Any idea? Have you read about it?
Because of the abnormal coronaries.
Normal coronary that can cause complete myocardial infarction.
Yes, sir.
Restrictive right heart physiology. The question itself is self-explanatory.
Yes, sir.
What happened? What are the components of tetralogy of Fallot? That goes to the basic question now. What are,
That is right ventricular outflow tract obstruction, overrating of the aorta, and large non-restrictive VST, and right ventricular hypertrophy.
right ventricular hypertrophy. Okay. So when the right ventricle hypertrophies, what changes will happen in its function?
Right
Will
ventricle
it have a
will
systolic dysfunction, or will it have a diastolic dysfunction, or will it have both?
both systolic and diastolic dysfunction.
Initially it will go for systolic dysfunction, then gradually it will go for, because of the stiffening, it will go for diastolic dysfunction also. Okay. So supposing you do a corrective surgery and there is a post-op right systolic dysfunction of the right heart, what will you do? How will you correct it? What drug will help to improve the systolic function of the right heart, right ventricle rather?
Mildrinon, sir.
Mildrinon, excellent. It's a phosphodiesterase 5 inhibitor, Mildrinon. Another drug?
Dobutamine, sir.
Dobutamine, noradrenal. three drugs which can be tried to improve the right heart contractility. And what about the diastolic dysfunction? What does it mean?
It's not able to relax.
Not
properly.
able to relax.
Relax.
What do you call that? Have just like chronotropy,
Lucid
inotropy,
trophy.
lucitropy. Okay. So lucitropy function is also decreased, and this will cause reduction in filling. Okay, and that will reduce the output, cardiac output. If it is not going to, even though there is a shunt, it will going to reduce the cardiac output, and that will worsen the condition. It will not allow the BP to pick up. Okay, so this is a very dangerous condition, which invariably results in failure of the surgery. Why this junctional ectopic tachycardia is happening? What is the reason?
So, because the
Do a
raw
corrective
fetus
surgery
close
for
to
the.
close to the bundle of his.
Very good.
There is
So when you
a
try to do the
junctional
septal correction, there is a possibility that you can damage the bundle of his during surgery. Okay, so this will result in conduction block, and the instead of sinus node, it will be the junctional node which will start taking up the contractility function. That will result in tachycardia. That may be not adequate to stimulate the heart, and that may be the reason why this can happen. Okay, so these are all the points that you have to keep in mind when you talk about the total corrective surgery for tetralogy of Fallot. Suddenly they may ask you about this child is very severely cyanosed. The cardiac surgeon feels it is not fit for corrective surgery at this stage. So what are all the palliative surgery, and how do you give anesthesia for that palliative procedure?
So, palliative procedure, they create communication between the systemic and pulmonary arteries.
Very good.
In the Blalock cross section, subclavian artery. In class section, a subclavian artery is connected to pulmonary artery, and in
Which
pod shunt,
subclavian,
water
right or
station,
left? Which
right
subclavian you
subclavian.
choose? You will choose the right.
Yes, sir.
It is more easier. What is the origin of subclavian in the right side? Is it a direct branch from the aorta, or is it a branch from something else?
The left side is direct branch.
Direct, left side is direct, right side
Direct branch.
comes as
Break it.
innominate artery.
Yes, sir.
Right. So innominate only divides into right subclavian and right carotid arteries. Okay, whereas the left carotid artery and left subclavian, they are direct branches from the arch of the aorta. So it is better to choose left subclavian rather than right subclavian, because it's a individual branch arising from the aorta. Okay, so normally left subclavian and either the right pulmonary or the left pulmonary, depending upon the size, because they may be undersized vessels because of the chronic outflow obstruction. They may not have grown into adequate size. So you have to open and select the appropriate branch of the pulmonary artery, right or left, and make a Gore-Tex graft is used to communicate 3 to 4 inches of the length of Gore-Tex graft. So they will do a side to side anastomosis. It's not an end to end anastomosis. This is called a side to side anastomosis by partial clamping of these two vessels and create a communication between these two things. So how to give anastomosis further? So this is a purely extra cardiac procedure. Heart is not opened, no communication is created inside the heart. So it is a purely extra cardiac surgery. Does it require cardiopulmonary bypass?
No, sir.
Not
Only
necessary,
for the
usually.
it's a
Unless the
corrective
child
surgery.
is very sick and you want to support the heart, you don't have to put the child in cardiopulmonary bypass. So it is by sternotomy or by lateral thoracotomy, it can be approached and the surgery can be done. Okay. So how do you give anesthesia for this child? You are not going to correct the basic defect. It is only a palliative procedure to improve the circulation into the pulmonary circulation to improve the oxygenation. Supposing after the surgery, the saturation which was 80 at the beginning comes to 98, will you be happy?
No, sir. Because there is a large, since the shunt is too large, there can be
Ah.
excessive pulmonary blood flow,
Hmm.
and inadequate systemic perfusion can be there. And
Hmm.
in long term, it can also cause the right ventricular failure. So
Okay.
target SpO2 is 80 to 85 mg.
Okay. Supposing after the shunt, the saturation drops to 70, what will
The
you tell
shunt is
the
too
surgeon?
small.
Shunt
Shunt is
is not
small,
working
so
properly. It is causing more problems. So you have to check the shunt and improve the size, or they remove the kinking, so establish a better blood flow. Okay. So you must get the same saturation as you start with when you do a palliative shunt surgery. You should neither get a excess saturation nor get a lower saturation, because lower saturation indicates decreased blood flow, and higher saturation increases too much of a blood flow. Both are not acceptable. Okay, so that is what you have to remember in this procedure. All the other principles like maintaining the SVR during induction and surgery, and trying to maintain the same saturation level throughout the procedure, and identifying any intraoperative hypercyanotic spells due to infundibular spasm. All these things you should be able to understand and correct, and try to maintain anesthesia. So what are all the drugs that are safe for giving general anesthesia, both for palliative surgery and for the corrective surgery? Right from induction to intubation, maintenance, and recovery. What are all the drugs? List the drugs that you can safely administer for a child with tetralogy of Fallot.
so fentanyl, ketamine, um,
Tell the
morphine.
name of the drug, induction agent,
These are
analgesic.
induction agent. Induction agent of choice is ketamine.
Hmm. Why
Opioids,
not
fentanyl.
propofol? Why not
The
propofol?
propofol will decrease the SVR, so it will
Hmm.
aggravate the shunting. So
Can you
we'll
combine
keep them
ketamine and propofol? Give a combination of these two called ketofol. Hmm?
Yes, sir. It can be. It
Yeah,
can be given.
that is another option. What about
Yes, sir.
etomidate?
So retomidate also can be given. It is cardio stable.
Okay. So in all cases where you want to maintain hemodynamic stability, please remember three deals. One is ketamine, but ketamine alone will cause increase in SCR and heart rate and secretions. And if ketomidate is very good, but there is always a fear of causing adrenocortical suppression. And ketofol, a combination of ketamine and propofol, 50-50%, seems to be ideal because it will neither increase the heart rate, which is deleterious in these patients, at the same time maintain the SPR to acceptable levels and produce better sedation because you are using lesser quantum of these drugs. Okay, so that may be a good choice for this case. What about the analgesic? Can you go for fentanyl and morphine?
Yes, sir. Fentanyl morphine can be given.
Morphine can be. What is the maximum dose of fentanyl that you can use for a corrective surgery of tetralogy of Fallot? Cardiac anesthetists usually dump the patients with heavy doses of, because we, as a general anesthetist, we are always tuned to using 1 microgram or 2 microgram per kg body weight. But the cardiac anesthetist regime always starts with 10 times more. So they may go up to 10 micrograms to 20 micrograms per kg, because they are happily going to put the patient on ventilator at the end of the surgery. So it always helps, does not cause any problem, even if you dump them with 20 or 30 max per kg of total fentanyl. Okay. So high dose narcotic is one of the methods of induction of any cardiac surgery patients. Okay. So cardiac surgery inductions are inhalation induction or high dose narcotic technique to maintain the cardiovascular stability. So this question may be asked. So you can even give up to 20 to 30 microgram per kg body weight, unlike your normal 1 to 2 microgram which you give for your routine general surgery, right? Okay. What about the relaxant of choice?
Sir,
Is there any-
atriapurin or dipyrin.
That is what you are routinely used, but for
Pan,
tetralogy of Fallot, panchronium and vecronium. Okay, these are the two things which are recommended. And what about the inhalation agents which can be safely used?
sevoflurane can be safely used.
Yeah.
And,
They don't recommend ISO as much as CO. Okay, right.
sevoflurane.
So what about the reversal? Do you reverse this patient or you straight away take them to ventilator?
They usually ventilate in this.
Mostly they are not extubated like your fast track anesthesia for other cardiac procedures. They are overnight or even 48 hours ventilation is carried out, and patients are monitored in the ICU. Okay. What are the common surgical complications that can warrant a re-exploration after a corrective surgery? Most common.
Heart block, sir.
Heart block is not, it can be corrected with your pacing and other things. Surgical complication. Bleeding, coagulopathy. Okay, so these children or these patients with the tetralogy of Fallot, they usually have a bleeding tendency. On top of that, you are going to give anticoagulants during cardiopulmonary bypass. Why they have a coagulopathy even in the preoperative phase?
Because of chronic hypoxia to the liver, there is abnormal production of there is decreased production of the coagulation factors, and there is
Do they have a
increased platelet
thrombocytopenia?
aggregation. Yes, sir. Because of
Why
hypoxia, there is
Is it because of
platelet aggregation.
hypoxia? What is the cause for thrombocytopenia in patients with tetralogy of Fallot?
Sir, absence of platelet maturation in pulmonary circulation, sir.
Platelet maturation as well as production. The bone marrow is engaged in producing more RBCs. They want polycythemia. Okay, so there is no equivalent or increase in the, or there is a lesser production of platelets, and maturity of platelets is also not adequately done. Okay, platelets once they come out, their number also is reduced. So that is why it's called thrombocytopenia. The total number of platelet itself is decreased because the bone marrow is engaged in producing more RBCs than the platelet and other white cells and other things. And because of the decreased white cells, there is a chance of recurrent infection. They are immunocompromised also. Okay, so that is the answer for that. The bone marrow produces more RBCs to counteract the hypoxemia. In the bargain, the other cells productions are decreased. So there is both thrombocytopenia as well as leukopenia. Okay, all these things cause these problems. So you have to keep all the thromboelastography is very important to assess the status of coagulation during and post surgery, so that you can avoid re-exploration and need for coagulation or correcting the blood loss that is happening. Okay, so these are all the points. So to overview, you must know about the components of tetralogy of Fallot. The main component is right ventricular outflow tract obstruction. The second important component is the large VST. The third component is overriding of aorta. The fourth component is hypertrophy of the right ventricle because of the obstruction. It is a sequelae. It doesn't happen immediately. It happens gradually over a period. So the primary important two components of tetralogy of Fallot, right ventricular outflow tract obstruction which may be intratubular, which may be a defect in the valve, or it may be a defect beyond the valve in the form of a narrowing of the pulmonary artery like pulmonary stenosis or atresia. Okay, so this is the main thing which causes the variants or the different types of tetralogy of Fallot and how they produce the different grades of cyanosis or hypoxemia. Okay? And once you understand that, the second problem is the communication between the right ventricle and the left ventricle, which is causing a right to left shunt instead of the normal left to right shunt because of the higher pressures in the right side, because the outflow is obstructed. And the questions about the during examination of the child, other clinical exam, we talked about cyanosis and clubbing, but what are all the auscultatory findings you will get when you examine the child?
So, a loud systolic murmur heard at the left second
Ejection
intercostal
systolic
space.
murmur at the
It normal.
pulmonary, if it is a pulmonary stenosis,
We
or that may be a murmur heard on the left border of the sternum also. Okay. So this is the clinical murmur that you may hear in these cases, and the heart will be the X-ray will be a boot-shaped heart. Investigations, and they may ask you why it is boot-shaped. What is the reason for the boot-shaped heart? It is because of the hypertrophy of the right ventricle. It rotates the heart, and the pulmonary conus, which is normally contributing to the left heart border, is not developed well because there is no pulmonary flow. So it forms a concavity instead of convexity, which gives the so-called boot-shaped heart. Okay, the two components which cause this boot shape are: one is the right ventricular hypertrophy, rotating the heart. Second is the absence of pulmonary conus or the enlargement which is there, which causes the depression, which is leading to this problem. Okay. And after the two common questions that are asked is about the corrective surgery. Of course, they may not trouble you much because it is a open heart procedure in a neonate or a child. The palliative surgery anesthesia, they may ask you. And the third one is the brain abscess. How will you give anesthesia if supposing the brain abscess in the child requires a drainage procedure? How to give anesthesia for that in an uncorrected tetralogy of Fallot?
same principles, the GA.
Same principles apply, but the trick here is, suppose you have to know about the intracranial pressure, because the brain abscess will cause a raise in ICP. If you use the same ketamine for increasing the SVR to maintain the prevention or aggravation of the right to left shunt, you may cause an increase in the intracranial pressure. Okay, so again, ketofol will be a better induction agent in this condition, and you can use fentanyl also for induction, and then try to avoid the sympathetic stimulation that is going to be caused by the laryngoscopy and intubation. And you can give so-called the scalp block also has been administered for older cooperative children who require a brain abscess, because it is only a burr hole and suctioning of the abscess, locating the abscess and suctioning. So the procedure is not too elaborate. They don't have to open too much of skull bone and all that. So it is usually done with a burr hole and putting a brain needle and aspirating the pus and clearing the whole thing. So adequate antibiotic cover, good hydration, and avoiding too much of raising intracranial pressure, but at the same time following the principles of anesthetizing an uncorrected tetralogy of Fallot child are all the points that you have to remember in these cases. Sometimes the tetralogy of Fallot patients who have a good flow into the pulmonary circulation, they grow up into adulthood also without corrective surgery. Nowadays, we are getting a lot of patients who have uncorrected tetralogy of Fallot who have gone on to become adults, and some ladies get married and get pregnant also, and they come for anesthesia for cesarean section. cases have been reported in literature. So how do you manage if supposing a lady with uncorrected tetralogy of Fallot comes for a cesarean section? How do you manage that patient? Can you give a spinal for that patient?
No, sir, again, there is decreasing history. So
Hmm. So
general
decrease
anesthesia
general
or
anesthesia.
or epidural.
Why not a phenylephrine
Epidural.
infusion and a combined spinal epidural? Prophylactic phenylephrine infusion you start and give a combined spinal epidural anesthesia. Is it advisable? You can do that. After all, what do you want to know? See, if a person has grown up to adulthood with corrective surgery for tetralogy of Fallot, you must understand that the severity of the disease is not very great. Okay? Because some amount of good blood flow is going into the pulmonary circulation. That is why they have been able to grow with the defect in the heart up to adulthood and even get married and become pregnant. That means they are not that much of a risky patients. Okay, so you don't have to worry. They may have mild hypoxemia, but they will not give you much trouble if you maintain the same systemic vascular resistance and keep the preload adequately. They will not give you any trouble. So there is no harm in giving a combined spinal epidural with a prophylactic starting of a phenylephrine infusion to maintain the SVR to avoid the blockade that is going to happen because you are giving the subarachnoid block. Okay, or elective spinal, epidural block with a catheter in situ and giving incremental doses also is not a problem. And if you plan to give general anesthesia, follow the same principles with a higher percentage of oxygen. And don't be worried because they may have a normal saturation of 80 to 85%. If you are able to maintain that and recover the patient at the end of the surgery, they will be doing good. So don't have to worry much about that. Okay, so these are all the points that you have to remember with regard to tetralogy of Fallot. I'll just show you a quick presentation on that. And